very much. It's a pleasure for me to ask Professor Rayaz Malik to present us diabetic peripheral neuropathy. Professor Rayaz is honorary professor of medicine and consultant physician at Central Manchester University Teaching Hospitals and University of Manchester. He is former president of NeuroDiab, the Diabetes Neuropathy Study Group of the AASD. And before, I want to present our congratulations for الأستاذة إناء الشلتوت، وأتمنى النجاح وكل النجاح لمؤتمرها الحالي والقادم إن شاء الله. شكرا.
Thank you.
Professor Rayaz,
welcome everybody. So
you have
I'm going to give you in the next 20 minutes an update on diabetic neuropathy. But I think it's important always to have some kind of personal link with the speaker, and for you to remember me for diabetic neuropathy, but also I have a conflict of interest to declare, which is that I am a Manchester United fan, and my one wish is that Mohamed Salah comes to play for Manchester United. Okay. So, diabetic neuropathy. If you distill it down, recently I was one of the authors of the diabetic neuropathy position statement by the American Diabetes Association, and we made three important points. One, that the most common forms of diabetic neuropathy are diabetic sensory motor polyneuropathy, which is somatic, and autonomic neuropathy. And all clinicians should be aware of these two aspects. In addition, neuropathy may be present in people with actually metabolic syndrome or impaired glucose tolerance. And this is an important move away from previous guidelines where we only said that it is only present in type 1 or type 2 diabetes. What we are saying is that neuropathy may already start in the pre-diabetes phase. And it's important as clinicians, we should start looking for this. And the third, and probably I think underserved or shall we say, discussed aspect is that not everybody who has diabetes who comes with neuropathic symptoms has diabetic neuropathy. Always look for other causes of neuropathy. So, what are the consequences of having diabetic neuropathy and diabetic autonomic neuropathy? Well, the major consequence is diabetic foot ulceration. And there is a recent review in the New England Journal of Medicine which puts together very nicely what are the consequences of having diabetic neuropathy and diabetic autonomic neuropathy. Essentially, it results in the formation of a diabetic foot ulcer as a consequence of sensory loss and abnormal regulation of blood flow and loss of sweating. So, if you have an ulcer, what happens? Well, this is the major consequence. This is Mr. von Bergmann in Berlin in 1901, and this is what happens if you don't detect and treat diabetic neuropathy early enough. The lifetime incidence of a diabetic foot ulcer is 19 to 34%. We're getting better at healing those ulcers in that 77% of those ulcers will heal within a year, but 40% will actually recur within a year. So we need to treat the underlying condition as opposed to treating the ulcer. Furthermore, the major consequence of having moderate to severe diabetic foot ulceration is amputation, and this will occur in 20% of individuals. Moreover, if you have an amputation, then actually your mortality at 5 years is huge. 70% of people will be dead after an amputation. And if you have end-stage renal failure and you have an amputation, then 74% people will be dead. And we know from these figures that actually I put together that the 5-year mortality for a person who has a diabetic foot ulcer is 42.2%. 1 in 2 people will be dead once they develop a foot ulceration within 5 years. And this is actually worse than most common cancers, which includes prostate, breast, colon, Hodgkin's, and bladder cancer. Only lung cancer has a worse 5-year outcome. So what do we do for the underlying diabetic neuropathy? So this is actually again from the ADA statement, where we put together the latest, science behind what is causing nerve damage. And what you see here is very different from previous statements, where hyperglycemia used to be the major driver of damage. We now acknowledge that it is not just hyperglycemia, but actually dyslipidemia, triglycerides, LDL, HDL, free fatty acids all play an important and probably equal role to driving diabetic neuropathy. And we know that this then causes further damage in terms of mitochondrial dysfunction. So that's from an experimental point of view. But what about from a clinical point of view? Well, this is actually, I think, a key study that was published now over 10, 15 years ago, which shows that not only glucose is important as a risk factor for diabetic neuropathy, but actually diabetes duration, being overweight, having higher triglycerides, having higher total cholesterol, and actually having a higher blood pressure are important risk factors for diabetic neuropathy. Let me just see if this works. And so it brings together a belief that microvascular disease is important for diabetic neuropathy. So, what is the evidence that improving blood sugar improves diabetic neuropathy? There is a Cochrane review which has looked at this, and what it shows you is that in type 1 diabetes, there is a significant effect of improving blood sugar in terms of diabetic neuropathy. However, in type 2 diabetes, the evidence, published evidence, and this is from big studies like the ACCORD study, actually suggests that there is no significant impact of improving blood sugar in type 2 diabetes on diabetic neuropathy. Now, that's the evidence. I would challenge that. I would say actually it makes sense that improving blood sugar improves diabetic neuropathy. And certainly, I think there is something to do with the way we measure neuropathy. So we actually try to address this in a recent study that we've done called the Qatar study, which is 231 patients with a HbA1c of 10% who are already on metformin and sulfonylurea. We then randomize them to either receive insulin, basal bolus, or a combination of pioglitazone with GLP-1 agonist. And what we showed, Abdul Ghani actually showed, is that you can reduce significantly the HbA1c by almost 3%. So this was the perfect opportunity to test whether in type 2 diabetes, improving blood sugar can improve neuropathy. And so we actually tested using technology called corneal confocal microscopy, which you see here, where we actually can scan live nerves in the eyes, and we can test whether or not the nerves are repairing. And what we actually show, interestingly, is that in this study, there is actually a significant improvement in terms of branch density and length of nerve fibers, small nerve fibers, when you improve blood sugar. So I believe, and this was type 2 diabetic patients. What about other things that we can do for patients? So I showed you the figure where blood pressure is important for diabetic neuropathy. Can we, by improving or treating people with blood pressure lowering agents, improve neuropathy? This is one study that we published many years ago, but I think it's important to note that these patients were not hypertensive. Average blood pressure was 138/76. They did not have microalbuminuria, but they had mild neuropathy, which we gave an ACE inhibitor. And what we actually show is that there was a significant improvement in motor nerve conduction, M-wave amplitude, and F-wave latency over 12 months, suggesting that actually not even lowering blood pressure, but treating people with blood pressure lowering agents can improve neuropathy. There is another study that was published from Italy, actually, called the DEMAND study. 380, this time hypertensive type 2 diabetic patients without nephropathy over 4 years. And here, they randomized people to either receive a calcium channel blocker or an ACE inhibitor. And they followed them over 4 years. And what they showed, actually, that you could reduce neuropathy progression by 40%. So if you were on placebo, that is, you weren't on a calcium channel blocker or an ACE inhibitor, then you progressed in terms of neuropathy faster than if you were on an ACE inhibitor, or actually if you were on a combination of an ACE inhibitor and a calcium channel blocker, you progressed the slowest. If you look at this figure, triglycerides and cholesterol are also important players for the development of diabetic neuropathy. Are there data that would tell us that by treating triglycerides or cholesterol, can we improve neuropathy? Well, there are. And this is a major study called the FIELD study, which was undertaken predominantly in Australia, where they randomized patients, actually 4,895 type 2 diabetic patients, to fenofibrate, 200 milligrams, or placebo. And the amazing results were that actually, you could reduce minor amputation by nearly 50% in patients simply randomized to fenofibrate as opposed to not being on fenofibrate. And it's a shame that they haven't done any further studies to look at the underlying mechanism, but I believe that that mechanism has to be neuropathy. Why? Because these are minor amputations, and we know minor amputations are driven predominantly by sensory loss and foot ulcers. We have also recently undertaken a study actually where we've looked at, so if you have a patient who has bariatric surgery, actually you improve their weight, you improve their blood sugar, you improve their blood pressure, you improve their lipids. So this is like a holistic approach. And what we've shown in 12 months actually, using corneal confocal microscopy, is that there is an improvement in all 3 parameters following bariatric surgery. So there is improvement in diabetic neuropathy with bariatric surgery. And you can see this here in terms of branch density, nerve fiber length, and corneal nerve fiber density. What about pain? Well, again, the American Diabetes Association statement pointed out that early in the course of disease, symptoms commonly arise due to the involvement of small fibers and include pain. And this, of course, is typically the patient comes to you and says, I've got hot burning feet, I have pain, pins and needles, lancinating pain. So how do you deal with people with painful diabetic neuropathy? This again is the ADA-DPN consensus statement, which shows you that we have a choice. So you have either the voltage-gated alpha-2 delta ligands, which includes pregabalin or gabapentin. You have the SNRIs, which includes duloxetine or venlafaxine, and you also have the tricyclic antidepressants, which evidence-based suggests that it could be nortriptyline or disipramine. Now, you can use either of these in the statement. However, if you have no clinically meaningful effect or if you have side effects from each of these, then you switch to another agent. But one key thing that we have actually included in the ADA statement is this, the use of combinations. So no longer do we start one therapy, if it doesn't work, stop it, start another. What we actually do is use lower doses of, for example, pregabalin with duloxetine or gabapentin with a tricyclic. So you start to use combinations, much like blood pressure, much like lipids, we are starting to use combinations in lower doses. But sometimes obvious conditions and treatments are the most difficult to grasp, or when big pharma isn't supporting the use of certain drugs, it never gets airtime. So I'm going to give you the other bit that honestly I think particularly working in the Middle East is relevant, and that is the relationship of vitamin D with diabetic painful neuropathy. So we did a study in Manchester, but we've done a similar study in the Middle East which shows that actually if you have painful diabetic neuropathy, then your vitamin D levels are half of the level that you find in people with painless diabetic neuropathy. And in fact, people with painless diabetic neuropathy are no different from controls. So suggesting that low vitamin D levels could be driving diabetic painful neuropathy. Is there evidence to suggest if you replace that vitamin D, can you improve painful symptoms? Well, we have done a study actually, which took 143 patients with type 2 diabetes. Their average 25-hydroxy-D level, however, is important to note, was actually 30 nanograms per mil, and most people would say that's normal. But when we gave 600,000 international units of IM vitamin D, and it went up to 46, look what happened to the pain scores. They all came down. So actually, increasingly, my first line is to actually replace the vitamin D and then think about other drugs for diabetic painful neuropathy. The other aspect is autonomic neuropathy. So there are now recent guidelines from the US which have tried to put together how we treat people with postural hypertension. So first of all, you have to make the diagnosis. And if you do a blood pressure after being 5 minutes supine, then at 1 and 3 minutes, and you get healthy patients won't drop their systolic more than 10, and their diastolic will go up by 2.5. But their heart rate will also go up by 10 to 20 beats per minute. If you have orthostatic hypertension, then you should get a greater than 20 millimeter systolic and 10 millimeter diastolic fall in blood pressure. But if your baseline blood pressure, which as is often common in most type 2 diabetic patients, is more than 150 over 90, then you have to get a more than 30 millimeter systolic and 15 millimeter diastolic drop for it to be postural hypertension. But how do you differentiate neurogenic from volume depletion? Well, the basis is on the change in heart rate. If you have a heart rate that does not increase by more than 15 beats per minute, then you have neurogenic hypertension, i.e. underlying diabetic neuropathy. If, however, your heart rate goes up to by more than 15 beats per minute, then actually you have volume depletion, or you're on too much diuretics, or there is another reason for postural hypertension. How do you treat it? Well, much like the ADA guidance, if you're not sure, refer to specialists. If, however, you think this is neurogenic hypertension, then first and most importantly, give them fluids. Ask them to actually take extra fluid, because we know that simple maneuvers like giving fluid or giving extra salt, not unless you've got diabetic nephropathy, can improve this. But in terms of drugs, the FDA-approved drugs, 2 drugs are midodrine and droxidopa. Midodrine, 2.5 to 15 milligrams TDS, and droxidopa, 100 to 600 milligrams TDS. And I must say, before I used to just use fludrocortisone, but I've started using midodrine, and it really works. It has a very good effect. The other ones we can use are fludrocortisone, but these are not FDA approved, and pyridostigmine. Again, you can switch agents and combine agents. The last autonomic complication, or one of the last ones, is gastroparesis. This is actually not common clinically overt. I have very few patients who get major nausea and vomiting. But we know that because of de-innovation, there are going to be changes in terms of impaired fundic relaxation, dilated gastric antrum, and actually pyloric involvement. So how do you treat gastroparesis? Well, there are medical therapies, and these include the dopamine receptor antagonists metoclopramide and domperidone, motilin receptor agonists, which are erythromycin, but erythromycin, remember, only works if you give it IV. It doesn't work orally. And then we have 5-HT4 receptor agonists such as cisapride, and there are newer agents called prochloropride and naronoprid, which are on the way, cholinesterase inhibitors against pyridostigmine, and there are also in phase 2b clinical trials ghrelin agonists. So these are the medical therapies for diabetic gastroparesis. For refractory gastroparesis, for the difficult patient who doesn't respond to medical treatment, the following. One is gastric pacing, which can be done where you insert a pacemaker into the greater curvature of the stomach, and actually it regulates release of movement of the stomach. The other is actually pyloric Botox. You can actually endoscopically go into the pylorus, and you inject into the pylorus and relax the pylorus, and it allows gastric emptying. And there are studies, open label, non-randomized studies, but there are studies that do show a benefit of both these approaches. The last is erectile dysfunction. And in the American Diabetes Association, we believe that there was we don't ask this as much as we should. So we should screen annually for erectile dysfunction. We should also check LH, testosterone, and prolactin. If the patient has a testosterone less than 12, then you treat it. However, we do not recommend treatment if anybody has a level over 12. That's the last slide. Can I just go back? Wait, sorry. The other key thing, hang on, yeah. The other key message I want to give to your patients who come in with erectile dysfunction are stop smoking. Why? Because actually there are studies that show if you stop smoking, you can improve erectile dysfunction by 25%. And honestly, to me, that is a really simple thing to do, and it's amazing how often now my male patients listen to me when I say stop smoking. And then, of course, we have pharmacological treatment, and pharmacological treatment isn't just PDE5 inhibitors. Actually, statins have been shown to increase the erectile function score, and there are other approaches we should consider, like alprostadil and like, thank you.